Just give everybody a moment to get logged in. All right. Good afternoon, everybody. Thank you for joining us for Astarte Medical's webinar presented by Dr. Sarah Taylor on promoting breastfeeding in the NICU and after discharge. I'm Tammy Jansen, co-founder and CFO of Astarte Medical. For those of you who don't know us, Astarte Medical is a precision nutrition company providing digital solutions to support nutrition and feeding practices for preterm infants in the NICU. We've been hosting a series of educational webinars, all focused on the growth and development of preterm infants and the importance of feeding, nutrition, and gut health. This is a look at our past webinars. You can view any of these webinars on demand by visiting our website at astartemedical.com. I'm excited to share our incredible lineup of upcoming speakers with you. You can also find the details for these upcoming webinars on our website. Please mark your calendars and join us for our next webinar on February 17th for a presentation by Dr. Chris Stewart on early life development of the gut microbiome and its health implications. Chris has researched the early life microbiome in health and disease for the past decade, specializing in infants born prematurely. In that time, he's published over 60 peer-reviewed manuscripts and has regularly presented his work at national and international conferences. Following his PhD and a fellowship in the UK, he moved to Baylor College of Medicine as a postdoctoral associate, performing both computational and wet lab experimentation. He then moved to Newcastle University as a Marie Sklodowska-Curie Actions Fellow and is currently building his lab focused on microbial host interaction in the gut. Within preterm infants, his research group is focused on necrotizing enterocolitis and late onset sepsis. Watch for the invitation to Dr. Chris Stewart's webinar in your inbox. I'm now pleased to introduce our esteemed presenter and expert in the field of neonatal nutrition, Dr. Sarah Taylor. Dr. Taylor is an associate professor of pediatrics at Yale School of Medicine. She's the director of Yale Neonatal Clinical Research and leads the Yale Neonatal Nourish team, which specializes in health outcomes related to maternal and infant nutrition. In addition to her NIH and foundation-funded research program, Dr. Taylor is an advocate for mother and infant nutrition at the international, national, and local levels. She serves on the Executive Council for the International Society for Research in Human Milk and Lactation. She's a content expert who leads quality improvement work in preterm infant growth and prevention of necrotizing enterocolitis for the Vermont-Oxford Network. While on faculty at the Medical University of South Carolina in 2015, she started the Mother's Milk Bank of South Carolina. We'll have time for Q&A at the end of Dr. Taylor's presentation. Please post your questions at any time throughout the presentation in the chat box on the right side of your screen. We'll compile all the questions and we'll get to as many as we can. I'll now turn it over to you, Dr. Taylor.
Thank you. All right, let's see if this will do what it's supposed to do. Did it work? I think it did. Okay, great. Hello, everyone. I'm Sarah Taylor. Thank you so much for the invitation to speak. I want to say before I start that those of you who have not heard Dr. Stewart speak, he's the speaker in February. He explains the microbiome in a way that I guess has made the most sense to me. So I really encourage you to attend his talk. He does a great job of taking some very complex information and making it to make sense. But today we're going to talk about the breastfeeding in the NICU and then after discharge and focus mostly on preterm infants, but discuss also some of our later preterm infants and term infants that find their way into the NICU. Let's see if it's not moving forward. Maybe I'm on the, there we go. Okay, great. So a little history lesson. I did start in neonatology in 1990s and 1999. And so I can say that this is from experience. And back in the 1990s, neonatology was, just still growing so much. And a lot of what we were doing with these very preterm and even, well, especially the extremely preterm infants, we were concentrating on survival. Could we do those things to have them leave the NICU and go home with their parents? And what we found was that mother's milk was associated with improved survival. So early on in neonatology, the 70s and 80s, it was seen that babies would grow better on formula and such, but then this understanding that that there was protection from the intake of mother's milk. And specifically, that protection was seen in necrotizing enterocolitis. These are some of the studies I consider the landmark studies, Rich Chandler's work and Linda Furman's, both showing that if babies who had at least 50 mLs per kilo per day of mother's milk, that there was a decrease in necrotizing enterocolitis. Paula Sisk did a similar study, but looked at 50% of the nutrition as mother's milk. And then the large NICHD Neonatal Research Network study by Mize and Dare that showed for every 10% increase in human milk in the first 2 weeks for these extremely preterm babies, there was significant decreased risk in necrotizing enterocolitis or death. So we realized in the 1990s we really needed to start having mother's milk for our NICU babies. Moving then into the next decade, survival was improving, but these infants were having long-term delays. So what could we do both later on to help these babies, but also in the NICU? What could we change in the NICU that would help the long-term development of our patients? And so studies have been done looking at human milk intake, specifically mother's milk intake, and the long-term neurodevelopmental outcomes. Now, these studies aren't ideal, and in human milk studies, especially in mother's milk studies, we're not going to have a randomized controlled trial and follow outcomes because we're not going to randomize babies to receive or to not receive mother's milk. But there are limitations in the studies beyond that. You see there that none of these studies had the neurodevelopmental outcome as the primary outcome of the study. Oh, excuse me, only the Furman study did. None of them did power calculations to make sure they had the right sample size. So yes, there's some weaknesses in these studies. However, one thing that's really interesting about them is that they've been done in many different areas of the world, which I think is great that this work is being done so many places. And then the other thing that's very interesting is how many of them did show this positive association between the intake of mother's milk and the neurodevelopmental outcomes. So in green are those positive associations where different testing scales and scores were higher in the infants who had received mother's milk or had received more of mother's milk than compared to the infants who had not received as much. And draw your attention to the Horwood study that's about halfway down. They actually looked out at mother's milk post the hospitalization, looked up to 8 months in these infants who were born very low birth weight and saw consistently continued improvement as there was intake of mother's milk after the NICU hospitalization. So bringing up that idea, we know that mother's milk is powerful intervention for the outcomes of our very low birth weight infants in the hospital, but we don't know as much about after the hospital. And this study showing that there did appear to be some benefit to the neurodevelopmental outcomes with sustaining mother's milk after hospitalization for very low birth weight infants. Now, all of these studies, there is work to be done. We have not adequately controlled for different characteristics that we know are related to mother's milk intake and to neurodevelopmental outcomes. So some genetic components, some maternal-child relationship components, and then also having a better inclusion of the social and structural determinants of health in these mother's milk studies and how they relate to long-term outcomes. So this work needs to be done. There's definitely room for improvement, but these are the studies that we have, the outcomes that we have to date. So then 2010, and I realize I'm going to have to add a 2020 plan to this slide deck at some point, but at 2020, I think we've all realized that there's been a big shift to recognize parents as parents, even when their child's in the NICU. Those of us who have been doing this before know there were times when there were visiting hours at the NICU, so there were only certain times that parents could come, and really now I think we've all realized that the parents should have 24/7 access, things to do that we're concentrating on, letting the parents change the diapers and be parents and be a part of the care of their infant. But along with that goes this idea of if mother had a plan to breastfeed, does admission to the NICU just mean that plan is thrown away? Or is there a way that we can protect mother's plan to breastfeed even when her infant is admitted to the neonatal ICU. So this is a big part of what I'm going to talk about today, is normalizing the preterm infant feeding plan. Can we do it? And can we even get it to be what mother had envisioned as her original feeding plan, especially if that included breastfeeding? So why would we want to do this? Why do we want to help our infants to continue to receive mother's milk after hospital discharge? Well, as I mentioned, it could be a wonderful way to support mother and her goals as a parent, but there also is the potential for health outcomes. Now, there are not as nearly as many studies as you would think looking at preterm infant intake of mother's milk post-hospital discharge and long-term outcomes. So we really end up having to rely on these studies that have been performed in term infants, and then making the assumption that the preterm infants would receive the same benefit. So this is a room, anyone on the call who's interested in research, there's a lot of room open for research and researching specifically the long-term outcomes of preterm infants receiving mother's milk post-hospital discharge. But for the term infants, you see there's decreases in infections and inflammatory and autoimmune diseases, and SIDS. And one thing I really like to draw people's attention to is this idea of early cessation. So if you look at the bottom area there, mothers who breastfeed or infants who are breastfed for 4 to 6 months versus infants who are breastfed for greater than or equal to 6 months. And this is interesting because I consider breastfeeding for 4 to 6 months as fantastic, especially when you think of how many women are going back to work and have other obligations in their life, and just really applaud women who are making it to that 4 to 6 month mark. But if we continue and if we encourage them and support them to continue past 6 months, there's going to be almost a 2 times lower risk of recurrent otitis and a 4 times lower risk of lower respiratory tract infection compared to breastfeeding for 4 to 6 months. So again, saying, I think we really need to be concentrating on supporting breastfeeding after our babies leave the NICU. There's also important outcomes for mom, and I hope we'll continue to make sure mothers are aware of the role of breastfeeding in her personal health. So decrease in cancers and decrease in cardiovascular disease have all been associated with mother's cumulative lactation. So I mentioned that there's not much known about preterm infants receiving mother's milk post-hospital discharge. This is it. This is really it, except for that neurodevelopmental study that I mentioned earlier. We had this one study showing the days of upper respiratory infections are lower with mothers receiving mother's milk. And you can see there it was significant up through about 7 from discharge to 7 months. But so much work that can still be done in this area. So whether it's to improve the health outcomes of the infant or to support mother's plan, what we want to provide support for breastfeeding and providing human milk, mother's milk post-discharge. But how are we going to do that? What can we do in the NICU to make that happen? You'll notice there's no references on this slide because there's not a whole lot of evidence for what I'm going to say right now. But this is something that I've worked with different interdisciplinary teams. I have to give credit to the teams I've worked with at institutions where I've been, as well as different institutions I've met with through the US. So this has kind of come up from all those discussions. But I think it is critical that we converse with mothers as soon as their infant is admitted to the NICU and say, what was your intention? And really talk to her about breastfeeding. Now many centers, you will see that there is a record in the electronic medical record that will record mother's intent, so you can see whether her intent was to breastfeed or to formula feed, and that's recorded at her admission for the birth. But it's still nice to have that conversation too. And it can be done by lactation consultant, by nursing, by physicians, by practitioners. dietitians, there's a lot of people who can have this conversation with mom, but be really important. I think it's important to know not only what her breastfeeding plan was, but also to know if she didn't plan to breastfeed. Some mothers really just plan to pump their milk, and that is their choice, and we need to be supportive of that. And sometimes when it's not documented that that's mother's plan, I find myself asking over and over again, because I'll forget and say, oh, did you plan to breastfeed? Should we be breastfeeding? And the poor mom saying, no, I've told you, I just want to pump. So I also don't want to keep asking her those questions. So asking early, and then making that a real part of the plan for the infant, the daily plan for the infant, to talk about mother plans to breastfeed. What are we doing to support that long-term health outcome, which is baby eventually breastfeeding? What are we doing during the NICU stay each day to facilitate that? It may not be a daily conversation when you start life at 23 weeks, but at least could be a weekly conversation as to if there's something more we could be doing. We need to recognize this decision can change, because there's mothers who didn't plan to breastfeed, but they start pumping. I've definitely had mothers start pumping and say, oh no, now I'm going to breastfeed. I did all of this work. Now I want the pleasure and the benefit of continuing with my infant. So that can happen. It can also, the opposite can happen as well. And then of course, once we're closer to oral feeding, really finding out, did mother plan to exclusively breastfeed? And of course, sometimes that's not going to work due to things going on with the infant, but at least know what her plan was. Return to work. This has happened to me where I'm working with mom and we're working on this exclusive breastfeeding plan, but the infant's discharge is being delayed. And all of a sudden we're about to discharge home exclusively breastfeeding. And mother says, you realize I have to go back to work in a week. So we're going to have to introduce bottles. So you do need to know all of those things that are coming up in mother's life too. And then recognize when there's opportunities that we can support the preterm infant breastfeeding, specifically the non-nutritive suckling, say during a kangaroo care event and such. And so I just, encourage everyone to start with this question. Mothers who are expressing their milk, thank you so much, but is your plan to directly breastfeed? Is that what you're going to do? And we need to know that and share that information. This is an example from Yale New Haven Hospital. I'm so excited that we've just come up with this in the last week. This was a piece of art by Mary McGuire. She is a NICU grad. She was in the NICU in 2000 and is now in college and art school, and has developed this as a little visual to be there in the infant's room. So when we walk in to talk to mom, we know if she's planning to breastfeed, and we can be sharing that information, and mom sees that we're sharing that information. I know a lot of other centers do the same thing, and that's wonderful, but really appreciate Mary developing this for us. Okay, so we're going to support breastfeeding. We've decided we're going to do that. But what are the different components then that we need to think about in order to do that in a way that is healthy for both the infant and for mother? So there's a couple of things that go into that plan for breastfeeding. One is mother's milk supply. So many women who plan to breastfeed, but with everything that occurs with the complications with the infant and with the NICU stay, unfortunately, some women then have difficulty sustaining that milk supply to the point where they can feed at the breast. And that's important for us to acknowledge and to figure out ways to support mother's milk supply. The maturation of the infant's oral ability, of course, is key for this. We'll go over that a little bit. And then the nutritional needs of the infant, and whether there is fortification or supplementation that is needed. With all of the attention over the last 2 decades to realizing that infant growth, preterm infant growth in the hospital is related to later neurodevelopment. One of those things that keeps me up at night is how to balance the development, especially of the brain. I would not want to be encouraging breastfeeding and supporting a mother breastfeeding if that then meant that the infant wasn't receiving the nutrition needed for optimal brain development. So finding that balance of supporting breastfeeding as well as that nutrition specifically for the preterm infant. So to sustain mother's milk supply, this is an old slide. I've been using this slide for many years. You see, I think it's 2016 is the last time I added a reference to this. So I put this here purposely. I'm going to show you the new evidence in a second. But this is what we've known for a while. And that is to sustain milk to greater than 40 weeks, so past the infant's due date, mothers need to express by 6 hours, perform kangaroo care, and express milk at least 5 times a day. And then some studies have shown to have adequate supply at hospital discharge, double pumping, so pumping both breasts at the same time, achieving 500 milliliters by day 10. There is an association between sustaining milk supply and comfort, breast pump comfort, and this comes to the importance of having lactation experts available to ensure that mothers have the right fit with the flange for the breast pump. That is a special skill to make sure mothers are fitted well. And then as well as having an environment, a NICU environment where staffing, nurses, everyone involved is aware of ways to support maternal breastfeeding that's associated with having supply through to discharge. Now there's some newer studies, and these are 2020 studies, so I just have 2 I really want to show. And first one is by Leslie Parker. Now, Dr. Leslie Parker is in Gainesville, Florida, and she, if you don't know her for her lactation work, that you may know her because she did the big randomized trial of not checking residuals any longer, and really showed no benefit to checking residuals in babies who are being tube fed. But Dr. Parker has also done some great work looking at how early a mother should pump. And in Dr. Parker's pilot studies, her early studies, it really looked like there was going to be a benefit to a mother expressing milk, specifically pumping milk, in the first hour after birth. And the data looked really promising for that, and it made sense. The biology made sense because we know that for a full-term infant or an infant who can breastfeed, that breastfeeding within the first hour of post-birth is wonderful for establishing breastfeeding. It also gives the baby that first bolus of nutrition to hopefully decrease the risk of hypoglycemia and such. So it made perfect sense, though, that the maternal hormones were perfect there in the first hour for establishing mother's milk supply with pumping. So Leslie moved forward, though. Those were her pilot studies that showed potential benefit of that. And then Leslie moved forward with a larger randomized trial. And you see here over on the left, her 3 groups were mothers who were pumping in less than 1 hour after delivery. The second group was mothers who were between 1 and 3 hours after delivery. And the third group was mothers who were pumping at 3 to 6 hours after delivery. And so they followed these groups through, and she had about 52 to 61 in each group, which is a great number for this type of study. But her results were different than her preliminary data, which I'm not quite sure what to make of that, but I think it's important for us to acknowledge this, and I just applaud Dr. Parker for doing this larger study. But you see here over on the right, looking at mother's milk volume in the first 3 days, the mothers who started expressing milk at 3 to 6 hours actually had significantly higher milk volume when compared to the mothers who had started expressing milk in hour 1. It doesn't quite make sense, right? First of all, you would think that the mothers who pumped in that first hour had that nice hormonal boost to have a higher milk amount. The other thought would be that the earlier you start, the more often you pump. But interestingly, that's not what Dr. Parker and her team found. If you look down at the next area of that table, the total number of expressions per day was higher in the late group on that first day than it was in the early group or even in the intermediate group. So potentially the reason that they saw the higher milk volume was that those mothers were expressing more frequently. But the study does, at least with these results here, and I'm not saying that we won't have future studies that show that earlier pumping, say 1 hour or 2 hours or 3 hours, is beneficial. But at this point, the research points to mothers need to initiate milk expression within 6 hours postpartum, which I think hopefully makes it a little easier for some centers that were having real difficulty getting these mothers expressing at that 1 hour mark. So something to consider. You were within the available evidence was supporting those mothers in the first 6 hours. The Dr. Parker study also brought up this idea of frequency and how often in the first or in a 24-hour period a mom is expressing. And I think this is something that I've seen in institutions where I've worked, that sometimes when we put all of our energy into that first milk expression, we kind of lose track of continuing to keep mothers expressing. And it can happen that all the mothers are expressing within 1 hour, 3 hours or so, but are they expressing 3 hours later or 6 hours later or such? That sometimes can fall through the cracks. So this work was done in the fantastic Human Milk Research Center in Western Australia, and they showed that they looked at the milk, the sessions, the number of sessions in a day, and that the frequency of pumping in a day and how that related to milk volume. So you see first there on the left, mothers were expressing milk 3, 4, 5, 6, and so many times a day. And what they found, that's per session. So you see there, it makes sense, that the lower, if you have a longer interval between pumping, so it's a lower number of times in a day that you're pumping, that for each pumping session, you would make more milk. That, makes sense because there's more milk there because you haven't pumped it out as recently. But that affects your daily production, of course. So there on the right, showing that really at least 5 times a day is associated with a higher daily production. When you're down in the 3 and 4 rate, you are at a lower daily production. And then the other piece of work, the other result from this study, is they looked at how long the interval or the association of the interval between pumping sessions and mother's milk synthesis. And here this is looking at the amount of milk that was produced per hour, so looking at the rate of synthesis, and found that the interval really there, when you got to be a 7-hour interval, is when you saw a real decrease in the rate of synthesis. And so these results together stating that you need to express milk at least 5 times a day, and you definitely not going longer than a 7-hour period. Now, if you remember my first slide that I've shown for years, it matches. That they said the exact same things. But I do want to say that anyone who's in this area knows every mom is different. And there definitely are those mothers who really need to express milk 8 times a day in order to keep their supply. And there's those mothers who just can't go any longer than 4 hours and keep up their supply. So I do think, and it'd be interesting to hear for other people in the chat or with questions. Do think that this is kind of the standard, but to help those mothers who may need more than this in order to keep up their individual supply. Skin to skin, is just so tied with lactation. And this was published in 2015, the American Academy of Pediatrics. Nice review of the evidence showing that it's associated with improved breastfeeding, milk volume, attachment, and so on. So lots of positives about skin to skin. And there's been some great studies. And, I still think we have some work to do in neonatology. Skin to skin, kangaroo care, still seen as this nice thing to do. We need to look at it as a medical intervention. This is an intervention that's associated with better outcomes in our babies. And we really need to see it that way and not see it as something that's just nice or touchy-feely. This is a way to improve outcomes in our infants. And you see this first study, these were very preterm babies who were breastfed or not breastfed, and the mothers who were able to sustain their milk 1, 2, 3 months and so on. This was significant at month 1, 2, 5, and 6. The mothers who were able to sustain their milk supply had significantly higher number of minutes for which they had performed kangaroo care. So showing that correlation between minutes of kangaroo care and breastfeeding outcomes. And then there has been a randomized controlled trial. These were in later preterm infants, 32 to 36 weeks. The intervention group had unlimited kangaroo care, and there was a longer duration of breastfeeding and longer exclusive breastfeeding. So really an important way to support breastfeeding in our population. The infant oral ability, I love this slide by Chantal Law, came together with this figure. So it is so complex. It is, we think of oral ability as your brain talking to your jaw and your tongue and your lips and such, and that's complicated, but it's more than that. It's what's going on with mom and her plans for lactation. It's who's doing the feeding and kind of their feeding technique and such. So it's very complicated, and you see up there in the top left, and stress plays a role into it too, infant stress, mother stress, or such. But very important for breastfeeding of the preterm infant is to understand the stages of the infant nutritive suck development. And this is also work by Dr. Law. And she showed that if you look at the different stages of suction and expression, she describes stage 1, which is, both of them, you see the sample tracings there, not much going on in suction and expression. And then you move into rhythmic expression in stage 2A. And so you see there that there is more of a nice pattern to the expression. And this is when a baby can bottle feed, because as you know, when you turn the bottle over, there'll be a drop of milk, drops of milk that are coming out. And so the baby can bottle feed just by kind of compressing their cheeks into the bottle rather than really needing suction on it. And it's not until stage 4 that there's well-defined suction that's there. And for breastfeeding, for most breastfeeding, suction is needed, which is why babies develop the ability to feed from a bottle before really having that good suction. So it's not that there's something better about the bottle, it's just the way that the milk comes from the bottle is something that the infant's mouth can do, whereas the suction is going to develop later. And just need to acknowledge this. Now, you've probably seen the studies from Sweden where babies are exclusively breastfeeding at 32 weeks gestational age, and you think, how can that's possible? I've had the opportunity to see that work presented and seen some lovely charts, and one thing I noticed was they had a little 32-weeker. That baby was skin to skin so much of the day, and truly to take in enough volume, it was many micro feeds through the day. So babies can feed at the breast, but to truly have well-established breastfeeding for everyone, you're going to need to develop this suction, and that's going to be more around 38 weeks or so for most infants. As you guys know, there's a big range for all of these milestones, and some babies are doing it by, say, 32 weeks. So other things besides just the skin to skin is to have the first oral feed at the breast. There's evidence showing that is associated with later breastfeeding, but also sustaining the feeds at the breast. I know sometimes it's all the concentration goes into that first feed at the breast and not so much then making sure we continue to have regular feeds at the breast. Infants who have a shorter hospital stay are more likely to breastfeed. I think that makes sense both with the degree of their illness as well as mother and infant ability to be together. Test weighing procedure is associated with higher breastfeeding rates. It's a valid method to assess the breastfeeding volume. There were some studies looking at post-discharge test weighing, and no benefit was seen to breastfeeding, but mothers did describe having that scale at home as beneficial. To look a little further into test weighing is a reliable procedure. If you look some work done at a Medical University of South Carolina with Dr. Hazy, this was giving the milk either through a tube or a bottle, so they knew how much milk the infant had received, and they did test weighs either without the leads on or with the leads on, and saw a nice correlation between intake and the test weigh value. So this is a valid method of measuring infant intake. Studies have been performed not only in the US, but in Australia and Sweden. It's really good, has this international support. We still though find that the clinical uptake of doing this is limited, and trying to figure out why. I still have nurses come say, I just don't like doing test weighs. I don't think it's reliable. And how can we have this great evidence, but yet have people who are there taking care of moms and babies still not think it's reliable. And I'm not quite sure what to make of that. I think we need to delve into deeper a little bit to see why it's still not been completely, taken in as the gold standard. Because the studies show there's no harm to maternal confidence, or her breastfeeding outcome. And also a fairly recent study from the Western Australia group this year, it's more reliable than any of the infant feeding scores we have available, including the BPAT or the PBAT that they were working to develop in the study. So really encourage you to work on test ways if you don't already have those established in your institution. Okay, so we talked about breastfeeding and ways to support breastfeeding, but then we have to think about nutrition. And this is, what do babies need post-discharge to support their growth, support their health, which is really bone mineralization very often, as well as their neurodevelopment. These are the studies that, the trials that have been done looking at nutrient enrichment versus no nutrient enrichment of mother's milk post-hospital discharge. Debbie O'Connor did this in 2008. Half the babies, these are all babies who were receiving mother's milk at discharge, which is about 38 weeks. Half of them were randomized to receive human milk fortifier for half of their feeds, and then the other group was with no enrichment. And her group found that the infants who were receiving some about 50% of their feeds with human milk fortifier up until around 52 weeks, that those infants had improved visual development. They were heavier, they were longer, higher bone mineral content, and the babies who were born less than 1250 grams had greater head circumference. They didn't see any difference in neurodevelopment, but they weren't powered to see difference in neurodevelopment. So really, this is a great study that really promoted enriching the nutrition for at least about 3 months after these preterm infants were discharged. The other 2 studies that have been done that were trials really showed no difference in growth or neurodevelopment with enrichment. So I, for many years, have worked to have human milk fortifier post-discharge. In South Carolina, we were able to have this covered by WIC, which was fantastic, that we could give this to all of our infants born less than 32 weeks. And again, these are her results, but another results there too. And it gets into that whole balance I've been talking about. So in her control group and in her intervention group, you see there was no significant difference. This is in the table. There's no significant difference in the weeks that they received human milk. But it sure makes you wonder about clinical difference, because the intervention group only had milk through 43 weeks, and the control group was closer to 52 weeks. So, and then if you look there was a significant difference at 4 weeks in the volume of milk that they received from breastfeeding, 89 mLs per kilo per day versus 51. So possibly there was a negative effect on breastfeeding with the nutrient enrichment. So because you can't add the enrichment to the breast, it has to be added to a bottle. Just a few other studies looking at mother's milk post-hospital discharge. This was from the Baylor group. They looked at babies who went home with mother's milk with 2 to 3 feeds of post-discharge formula compared to those who were just formula fed. And they didn't see any difference in growth at 12 to 15 months. And then this is some work that we did at Yale. This is Diane Lee, who is now in Kansas City. And we looked at babies who were supplemented with preterm infant, the transitional formula added to mother's milk, or supplemented with HMF added to mother's milk, or babies who were receiving mother's milk and then separate feeds of formula. And we didn't see any difference in their growth patterns, their change in weight Z-score up through 6 months. So a lot that we still don't know, unfortunately. This is some work I'm continuing to work on to figure out the optimal way to balance infant growth and breastfeeding post-discharge. So we started that work with this study that I'm going to describe. So in I first was working on a study of vitamin D, and I would see these mothers at hospital discharge and then see them around term age, when it ended up being about 2 to 4 weeks after the baby had gone home. And what struck me as we worked on the vitamin D work, but when I would talk to these mothers that had left the hospital with great milk supplies and really excited to continue to provide their milk, they had already stopped providing their milk. They'd already stopped pumping by 2 to 4 weeks post-hospital discharge. They were exhausted. We were telling them to triple feed, which is to pump, or excuse me, to breastfeed, then to pump, then to feed the pumped milk by bottle. And if you're going to feed every 3 hours, and that takes about an hour and a half, there's not much time for anything else for you to do, including sleep and showering and such. They were exhausted. So we started to look at we developed this study to look at a way to maybe support these mothers in breastfeeding post-hospital discharge. And so there were, we built on evidence-based techniques with lactation support and electric breast pump availability, as well as these mothers were able to do the test weighs at home. And this was a study that we performed in South Carolina. And we were working to figure out how can we support these mothers and babies who are leaving the NICU in Charleston, South Carolina, and they're going, potentially 2 hours away. So we can't bring them back to Charleston to support lactation. That's not going to support lactation for mom to get in a car and drive 2 hours and then drive 2 hours home. So we decided to put the lactation support in the clinics, and these are clinics that did not have IBCLCs or lactation support of that degree at this time. And so we randomized half the practices to the intervention and half the practices were control, and tried to do that based on the diversity in our population. The mothers were blinded to what site they were going to at the beginning, but then of course they knew if they were getting the intervention or not. And we also looked at, this was also an implementation study to see how pediatricians and pediatric nurses, the lactation counselors we trained, felt about their participation in the study, as well as mothers. This is the study. We ended up with about 26 and 22 in each group. This was a population that was mostly Black and Medicaid recipients as well. And you see there wasn't a difference between groups. There was a difference in groups between employed during pregnancy. I'm not quite sure what that happened nor what that means for the results, but just wanted to report that. So we didn't find any effect of the intervention. So it was a negative study. We didn't find an effect of the intervention. You see there the controls and the intervention, the number of mothers providing their milk at 2, 4, and 6 months was not statistically different. And even when adjusting for things like gestational age and such, there was no difference between the groups. We did, however, see higher breastfeeding than we ever expected in both groups. And it really brought up that idea of, even just participating in the study, could that be all that is needed for these mothers who had already established a milk supply in the NICU? So the intervention didn't make a difference, but of course mothers who were giving their milk at 2 and 4 months were more likely to be giving their milk at 6 months. That makes sense. The other thing we were surprised we didn't see is we didn't see a difference in education. And the reason we were surprised is other studies we've done in South Carolina, we've seen a difference by education. And so that really surprised us. The other thing, though, that we're going to delve into further is we did see a statistically significant difference between infant sex, and where the male infants were less likely to still be receiving mother's milk at 6 months. In fact, the female infants were 58% increase of receiving mother's milk at 6 months. So looking into that a little bit more, there's some great work being done elsewhere in the country talking about how mothers may not perceive that they're making as much milk for a male infant, and it's this perception, because 57% of our mothers said that they stopped providing their milk because of low milk supply, which is interesting because these were all mothers who had sustained through the hospitalization. So a lot for us still to delve into based on the results of this study. I'm going to quickly go through, I realize I'm going over, and so I'm going to go through this a little bit more quickly, but when I sent out the information as to what would be covered. I put a lot in there to be covered in this talk. I was so excited to give it. So I want to fulfill my promise and cover those areas that I mentioned I would talk about. So we're going to talk about some other disparities in infant feeding in the NICU. I had the opportunity to work with Kim Doty. This is Kim. She is here in Connecticut, and she did this great study. This is how I tracked her down. So I saw this, I read the study and thought, oh wow, I need to meet the woman who did this. And this was looking at data from the U.S. Infant Feeding Practices Study 2. And what she found, this was looking at mothers with gestational diabetes. You see this list of reasons that are differences between mothers with gestational diabetes and mothers who do not have gestational diabetes. And I really want to draw to your attention to the one that's about halfway down. Women with gestational diabetes are more likely to say their physicians prefer formula feeding. Think about that. And you think at first, oh goodness, who would do that? And I can tell you from experience, I may be one of those physicians who made a mom feel that way. And this has taken a lot of introspection to realize this. But as a NICU care provider, I would see these babies with maternal diabetes. If we're not giving formula, if a mother says, I plan to breastfeed, I would associate that with a higher risk of that infant needing our NICU care. And in order to keep mother and infant together and such, that idea of let's give some formula and then maybe you guys can stay together. But how, you see it this way and you think, oh, how sad that these mothers are picking up on that perception and not feeling completely supported in lactation by their physicians. So this is something that I've had to come to terms with personally, as well as we need to be working more on this on a systems level. And again, this is the women with diabetes are even though they plan to attend to breastfeed, if you have diabetes, only 65% are initiating had initiation of breastfeeding, whereas 92% of women without diabetes and mothers with gestational diabetes were over 3 times more likely to introduce formula in the first 2 days, initiated pumping later, and but they were not more likely to report breastfeeding difficulties, which is very interesting because we all assume there's breastfeeding difficulties. They were experiencing problems, but not reporting those difficulties. So how much of that is kind of our response to women with diabetes? Another area that we're getting into are racial differences, and not only recognizing that there's racial differences in breastfeeding initiation and breastfeeding outcome, but where does that problem occur? And this is another area that I at first had to do some personal introspection to realize that there definitely was a time that a mother who was coming from a certain hospital where her baby was being transferred in, a hospital I knew was supportive of breastfeeding, a hospital that I knew was more likely to have white, upper middle class, educated women, that when I heard that baby would be coming in, I would say to the nurse practitioners or to the residents, oh, make sure we find out if mother plans to breastfeed because we want to be supportive of that. Then there was another hospital in South Carolina that was more likely that the mother was younger, was on Medicaid, was a Black race. And I knew that hospital really didn't do a whole lot to support breastfeeding. So it wasn't, I wouldn't rush to think, oh, we need to know mother's plan. And baby friendly, we did baby friendly across South Carolina, just really opened it up where you had to ask every mother her plan because every mother was going to be educated. So much that we're doing to work to give support to every mother, no matter what her culture, background, or expectations, that she would be a breastfeeding mom. But yet we still see difficulties. And so this is going to be published in Breastfeeding Medicine shortly. This is work done by Shauna Hemingway, who is an OBGYN resident there in South Carolina. And she found that we, with going baby friendly, that more Black mothers, we got the rate up to 60%, were planning to breastfeed, up from 52%. And that was a significant increase, and more so than for our non-Black mothers. But even in those 2 to 3 days in the hospital, Black mothers were 2.4 times less likely to sustain breastfeeding through to the day of the infant's discharge, or so the mother's discharge. So still had work to do, and potentially this is related to racism in our system and how we're approaching these mothers of different races in our support of their breastfeeding. So much more work that needs to be done in this area. Here at Yale and other institutions, I know we're developing couplet care rooms. It's really excited. This is a picture of couplet care. So mother receives her postpartum care in the same room as the infant receiving NICU care. How great to not force that the mothers and the infants have to be separated. And so since this was one of the first couplet care centers, academic centers in the US, I thought, oh boy, we've got to study this. So it's our role, it's our job to look at the evidence. So we have started working on this. One of our fellows here at Yale, and this is her data for 26 dyads, and you see there they did end up being more of late preterm or term age. But she did find that so these were women who experienced couplet care compared to women who qualified for couplet care but did not experience, either because there were no rooms available or sometimes because they chose not to. And we'll describe all of that in the paper. But she did see the mothers who planned to breastfeed, that those with couplet care, much more breastfeeding and percent of maternal milk, as well as less feeds given by the staff. More feeds were given by mom or dad or other partners, mother's partner. So that was exciting to see. We're starting to look at breastfeeding outcomes. It's a little too early in our data to say much with that. So breastfeeding is natural, right? None of us would be here if someone in our past hadn't breastfed. Breastfeeding is just intrinsic to being a human being, to being a mammal. So we should all just instinctively know how to do it. And this should just be part of the natural experience of a mother. Well, we don't live in a natural world, and especially in the NICU, that the world is not natural. And so we have to get away from thinking of mothers should just know how to do this and should just be part of being a woman, and instead realize that nothing's natural in the NICU. And so we've got to continue to do this great research I've presented to figure out evidence-based ways to support mothers in our unnatural world, and to empower them and help them achieve their goals. But I also want to mention that even though we're supporting breastfeeding, we're supporting mothers' educated choice for breastfeeding. These other ways of feeding, bottle feeding, tube feeding, they are also natural. They are also the way things work in our world. And we need to be equally supportive of mothers with those choices. So it's empowering the mother with education, with knowledge, for her to make her choice to achieve her or their feeding goal, and then being supportive of what that goal is. So this is a summary of some potentially better practices, and most of it I have covered, but I think it makes sense. So discuss mother's plan, keep talking about mother's plan, establish her milk supply, feed at the breast, use test ways, understand oral development, discharge breastfeeding support. I didn't get to go into that as much detail, but one thing is just to make sure the pediatrician knows that a mother plans to breastfeed. So, because so many pediatric practices are now really building their lactation teams, so that can really benefit our mothers. Then we don't know how to nourish these babies post-discharge, where there's not adequate evidence as to how much supplementation is needed. So the main thing I can tell you right now is feed the baby to grow them, follow their growth. And again, that's something important to pass on to the pediatrician. And they may be eventually able to exclusively breastfeed. I'll never forget, we had a baby in South Carolina who the mother contacted one of our lactation consultants, I think at 9 months, to let us know that she'd finally exclusively breastfed him for a day. He had been born at 28 weeks. So really, just amazing to support these mothers and these goals that they have. And then there's just so much more for us to learn specifically about maternal disease, race, other factors, their togetherness, other ways that we can make sure nobody's slipping through the cracks when it comes to lactation and achieving her goals. And I just want to say thank you to others who are on our Nourish team at Yale, as well as acknowledge those who are involved in this Please for Preterm Infant study that happened in South Carolina. And I'll go back and I'll leave it on this so that you can look at these, and I'm happy to take some questions.
Thank you so much, Dr. Taylor, for a great presentation. So everybody, if you have any questions, please post them in the chat box, and we do have a few to get started. How often would you do the fortifier shots with breastfeeding? How much supervision was provided, and were any labs drawn?
Great question. So the fortifier support with breastfeeding, they if I recall, I don't remember them having labs in that study. They did have the DEXA scan, so they looked at bone mineralization, as well as some visual neurodevelopmental and weight length and head circumference. And it was 50% of the feeds, and they let mothers figure that out. They just said 50% of the feeds need to have fortifier added, and they've let mothers figure that out on their own. This is an area, I mentioned, just showed my data. I've been a big proponent of the human milk fortifier post-discharge based on my data and others. I'm not 100%, or I'm not sure how much of that is needed, if at all. I think we have to do more studies in this area to know. And I'm more positive about mothers being able to really eventually breastfeed, because one thing is, if an infant does not have neurodevelopmental, so it doesn't have, say, bad intraventricular hemorrhage, and is able to use their mouth okay, and doesn't have bronchopulmonary dysplasia or heart disease, I think around 44 to 52 weeks that they will feed to grow. So they will take in, if mother's supply can respond to them, they will take in the milk they need to grow and to develop. So I think that's one thing, is how much extra nutrition to give them may not be needed once they're going to just take in what they need to grow.
Great, thank you. How do you recommend determining supplementation for premature babies? Besides test weights, do you go to a sliding scale based on quality of breastfeeding? If so, when?
We just use test weights, and I'm really excited that in my institution, we will take a test weight volume and put that in the medical record, as that is the feed. So I would encourage you to read the references I provided. These are people who've really worked in this field, and it's interesting when you have people from Sweden, from Australia, from the US, all saying, we tried to figure out a different way to do this, and it all comes down to test weights are the way to go.
All right. Our NICU needs more lactation consultants, but what is a way that we can better support breastfeeding without the additional expert assistance?
Oh, that's a great question. I would start with just talking about it. So really having it be part of the conversation. One way to do that is to go to the management of the different disciplines in your NICU and make sure that they have lactation education. So I think it should be mandatory, if you're a NICU nurse, that you should have mandatory education on how to help mothers start pumping and start breastfeeding, and understand the simple support. And I think it's the same for physicians, for dietitians, for respiratory therapists, and when we worked on becoming baby friendly in South Carolina, we realized that we needed to educate the women, or the services, the environmental services going into the room to say empty the trash. Moms would ask them breastfeeding questions, so we empowered them with some simple answers. They were then able to support moms. So really realizing that education has to be universal, needs to be the front desk staff, it's got to be everybody, and making that mandatory, and then increasing those conversations.
Thank you. Do you have suggestions for staff and neonatologist buy-in? I work in a level 3 NICU where volumes drive discharge.
Oh boy, yeah. So that's a big problem. It's a really big problem. We're so focused on numbers in neonatology, and then we set these mothers up to be focused on numbers, which I think is one reason they have trouble at home, is that we've just trained them to be so focused on a number. I think it has to then come from this kind of wave in neonatology of letting parents be parents, of family-centered care, that wave of family-centered care. Let's focus on what mom and dad are saying to this, and let's let them make the decisions that are theirs to make. And one decision that is theirs to make is the feeding of their infant. I think we still have work to do to see how breastfeeding in a NICU relates to discharge. And I think I'm hoping we can find that there's ways to do this, and we can do the right studies to show that it doesn't delay discharge. And when we have those studies published, then course, you'd be empowered to take those to your team. But I think it has to come from people respecting the role of the family and making these decisions.
Okay, great. We have time for one more question. Do you think promotion of donor milk undermines mothers' drive to breastfeed?
Yeah, it's a great question. There's been different studies that have shown different answers. There's definitely some studies that have shown that it had an effect, and there's more studies that show that it doesn't. I think it's very important to inform mothers as to how donor milk is not equal to her milk. Donor milk has been shown to decrease necrotizing enterocolitis when it's supplementing mother's milk, is what most of the evidence is. It does not have an effect on neurodevelopment. It does not have an effect in infection standing alone. It really seems to be a necrotizing enterocolitis effect. So I think it's important for mothers to know that donor milk is not equal to mother's own milk.
So we had 2 more questions come in. Do you have time for those?
Yeah,
okay. Are we looking at the right outcome when we focus on weight gain primarily?
Oh, so yeah, that's I know Tanis Fenton and Bill Hay did the first one of these sponsored talks. We don't know how best to grow babies, and with body composition, length, is it just weight gain? I can tell you that in the studies that have looked at growth in the hospital, that weight gain is the factor, is the variable that's most commonly associated with later neurodevelopment. So I think in hospital growth and weight gain at this point seems to be the best marker for later neurodevelopment. That is not true post-discharge. There are not nearly as the number of studies, and in fact, then there's studies that don't show the same effect. So I really don't think we know how to grow babies post-discharge and what's the proper weight gain. So I think, shooting for what we'd shoot for term infants in that 25 to 30 gram per day range is something that's acceptable in post-discharge, rather than working to have this exponential catch-up post-discharge. But again, we don't know that completely yet, but definitely if someone's saying, oh, this baby has to grow a certain way post-discharge, you can answer, we don't really know that, because we don't.
Okay, and then finally, when a mother wants to breastfeed, how is the plan communicated to the community provider to ensure that plan is supported?
Yeah, so that is something I've worked on a lot in South Carolina, and I haven't quite done as much work. Continue to work on this in Connecticut. So in South Carolina, and this was actually taken, I think Jay Kim's going to be a speaker in a few months. This was taken from the San Diego program. We had, we called it the Preemie Feed Sheet. I think it was facilitating enteral education at discharge. So had to make it have a cute name. But this was faxed to the pediatrician with a discharge summary. And this was to tell them what the feeding plan was. It showed some other options for feeding plans if mother changed her mind and decided she didn't want to breastfeed or such, and told them maybe some risk factors for that specific baby. So I do think we've got to do more to communicate with pediatricians. The other thing that we did there that still wasn't enough, we started a post-discharge nutrition clinic. And in that clinic, we found that 17% of the families were mixing the feeds incorrectly. We saw a lot of babies who were still losing weight or not even growing at the weight gain that we would expect for a term infant. So would kind of be our lowest threshold. So yeah, there's a lot still to be done for communication with the pediatrician. I would encourage you, for those moms who plan to breastfeed, have them find a breastfeeding supportive pediatrician. Empower those moms to find a pediatric clinic that is known for supporting breastfeeding. And many of them do now have lactation consultants, IVCLCs or CLCs on staff. So I think it's great for moms to find that support post-discharge.
Great. Well, I want to thank you so much, Dr. Taylor, for your time and your insights. And thank you to all the attendees for joining us today. Please come back on February 17th for Chris Stewart's presentation, and hope to see you all then. Right. Thank you.
Thank you.
Bye-bye.
Take care. Bye. Oh,